Apparently the new fellows, apparently the new fellows aren't available, so it's going to be a
Yeah,
small,
they're doing DME orientation, Pam, so they'll be with us later today.
Yeah, I already mentioned that.
and they can watch the
And
recording.
they'll
So,
watch yeah,
Yep.
exactly.
okay, well, let me introduce Mark Myer. Uh, Dr. Myer is family practice and addiction medicine certified. We worked together for a number of years at Hazelton here in Center City, Minnesota. Um, he has worked in the healthcare professionals recovery programs. He has, um, then he went off and got an MBA. And most recently, he has taken this position as medical director at Cirque Lodge in Utah. So thanks for coming back by Zoom to give us this talk, Mark. Great to see you again.
Great to see you as well. Thanks for having me. So I'm sharing right now is my full screen sharing with my PowerPoint and everything.
Yes,
Okay, great.
okay, your slides.
Yep. All right. So yeah, anyway, I'm originally from northern Minnesota and moved around to different places. Now I live in Utah. So that's a whole new culture and experience. So one of life's many changes and opportunities. But anyway, yeah, so I had left addiction medicine for a while and went back to school and then did general family medicine for a couple of years. However, realized that I was doing, again, a lot of addiction medicine, doing general family medicine. And, I worked in a small town in central Minnesota and, uh, unfortunately, there wasn't a lot of availability of 12-step programs. Um, the folks that I saw, there was a lot of methamphetamine misuse and addiction, of course, a lot of alcohol misuse and addiction. These were folks that generally were below the poverty line, a lot of single moms, and the expectation that they were going to be able to first of all, find a treatment that could take them. Number two, leave their jobs and or family for any amount of time. Um, and then, three, be able to just quickly incorporate back into their quote unquote usual or normal lives, was a not a great setup for them for long-term recovery. I always consider myself really lucky to be in areas where AA and other 12-step programs are available. And we're going to talk more about this. AA is available all throughout the world and is overall has grown in the last couple of decades. But there are still places in the U.S. where there may be one or two meetings per week, and it can make it more difficult for folks to, if they've started a 12-step program, let's say in treatment, to continue that or to begin just right out of the gate in a 12-step program. But I want to talk about how successful they are because they are so widely available and relatively inexpensive. So we'll get going. Come on. There we go. So why do we examine AA? This is sort of old data from the NESARC, National Epidemiologic Survey on Alcohol and Related Conditions. I think this was for the first wave, 2001, 2002. But even back then, there was, realized 30% lifetime prevalence of any alcohol use disorder. That hasn't changed a whole lot over time. One thing we do know is that there are tons of people that need treatment, and only about 10% of those that need treatment actually receive it. This was from the NISDU, or the National Survey on Drug Use and Health, from 2008. Again, unfortunately, that hasn't changed a whole lot. It depends upon how you define treatment, of course. But in general, we're talking about kind of any dedicated program that would address addiction from a healthcare standpoint. This is from 2022, the most recent NES. So the NESDU National Survey on Drug Use and Health is an annual survey that's sent out to try to determine what the burden of addictive diseases is in the population of the United States. And then, they look at more granular data to, determine different segments of the population and what are people starting to use, right out of the gate? What do they continue to use, et cetera? From 2022, they thought that, at least those folks, that they had surveyed, 24% of those received treatment for substance use disorders. That was amongst those that had been surveyed. But most people, don't have access to treatment. And even if they do, there are too many barriers, including shame, that keeps them from treatment. So AA and 12-step programs are really important to be available for folks. It's kind of a low threshold or a low bar of entry into 12-step programs. You don't have to go to a special place to, do 30 days of treatment and spend tens of thousands of dollars. There are many people that just enter the rooms of AA and NA and other 12-step programs and, find a way into lifelong recovery. Why examine AA? Also, they found that, this has been known for a long time. More people use AA than any other resource to address problems with alcohol. And that's just because of its, wide availability. They're accessible, inclusive, diverse, growing, inexpensive, successful. Accessible. I've been to AA meetings in many different parts of the world. In Vietnam, I attended an AA program, an AA meeting. I went to an AA meeting in Belize. Unfortunately, I was the only one that showed up because as I was walking to the AA meeting, one of the bars had a sign that said, AA is for quitters, which of course had dual meaning, but they weren't. It wasn't set up in Belize, the place that I was staying at, for us folks that don't drink and or drug anymore. And it's also important to know that 12-step programs are successful. They can get a bad rep, bad name, and there are many folks that criticize what they stand for, but you can't argue with the fact that being accessible and successful is a great combination, and being inexpensive. So this is from 2020. There are about over 2 million AA members worldwide, active, almost 130,000 groups. And, it's found in over 180 countries and over 100 languages. The last I heard, it had been translated into the Hmong language as well, which I understand is a very complex language, not a Romance language, difficult to understand and speak. But what a wonderful thing that people have taken time to translate this message into all those different languages. And as you look back over time, the number of active groups or active members and groups has gone up, even if just by a few, tens of thousands per year. Interestingly, no study has shown that there's more than one demographic group than any other, that it's a true cross section. I mean, if you walk into an AA meeting in a basement of a church or wherever it might be, you're going to find that there are generally more men attending than there are women. But part of that is that men have twice the rates of alcohol use disorders as women. So if you were considering that as a cross section of those that have alcohol use disorder, maybe that kind of makes sense. And as far as inclusivity, there are many different flavors of 12-step meetings and AA meetings as well. I mean, there are AA meetings for um, those that believe in God. There are ones for those that don't believe in God. There are those for, kind of focus on LGBTQ plus folks, and also those for professionals, like for me, for physicians and other healthcare professionals. So, you can find like folks if you don't even have to really try that hard, but they're out there. Research has shown that severity of alcohol-related problems is the strongest predictor of attendance in AA. Part of that is that, it's sort of, many people say it's the last house on the block for them. They'd tried many other things first, but finally had reached a point of desperation, very severe alcohol-related problems, which finally prompted them to attend AA and or other 12-step programs. And those with weak or inconsistent family and friends providing support are also more likely to join AA. So, if you can't get support from home, if there's somebody that continues to drink at home or use drugs, people really do find solace in a whole new group of healthy people to recover with when they go to 12-step meetings. Gender, like I said, has not been found to be a predictor of AA membership. Uh, People will argue that, but I think it does have to do with the epidemiology perspective of those that have alcohol use disorders. And we'll talk a little bit about Project Match, but it also showed no gender differences in rates or patterns of meeting attendance. And from 2014, again, about, double the males versus females that were attending AA, and maybe that makes sense from the rates of alcoholism that are gender specific. Going way back to the 1980s, my goodness, the days before digital phones, when we used rotary phones. If anybody still remembers what those are, the Institute of Medicine looked at, we're discussing 12-step programs in AA, and they realized that although it's the most widely used approach, or one of the most widely used approaches for recovery in the United States, it was probably the least rigorously evaluated. And we'll also discuss a little more on why that is, why it's hard to study AA. So this is from Alcoholics Anonymous, what is currently known, which was an article published in 1993, saying that research was mostly pre-experimental in design. There was no recheck or backcheck for validity of self-reported data, and was unrepresentatively large number of middle-aged men and small number of women that had been researched. Most of the early research and even continued research in Alcoholics Anonymous has been done on those that go to go through the VA hospital system, and it's a large percentage of those have and continue to be men. So that partly explains the research disparity there as well. But those that were professionally treated who had then attended AA, either during or after treatment, were more likely to do better afterwards than those who didn't attend AA. So although it wasn't rigorously studied, again, it was confirmed that folks that went to AA seemed to do a lot better. There's some Journal of Studies on Alcoholism. No, it's Journal of Studies on Alcoholism and Alcohol and Drugs, I believe. They also decided that, yes, indeed, the experimental rigor on AA studies was poor, but of those that were better designed studies and, not just sort of informal surveys that, again, AA attendance showed moderate and positive improvement, moderate and both moderately and positive relationships and improved psychosocial functioning. Again, going back to those that have unstable home life and or folks in their original friendship or friend ring, may go to Alcoholics Anonymous to find a more healthy cohort. So this was a bummer for those of us that do, alcohol and drug related treatment. This was a Cochrane review from 2006. Cochrane is the Cochrane database of systematic reviews. It's sort of the gold standard for meta-analyses, and these folks look at hundreds and thousands of articles, and the whole team gets together and decides whether the articles are of value and whether they are of good experimental rigor. They put this all together and then sort of make a statement at the end that kind of is taken as the truth, going forward until the next Cochrane review comes along. So from 2006, they studied, it was about a couple thousand folks. It was 8 different studies that included a couple thousand folks. And in the end, they found that there really wasn't any evidence to show that AA could do anything to help achieve abstinence, but it also showed that it, probably didn't harm anyone. But they recommend those attending AA or TSF programs. Now, TSF is different than AA. TSF is called 12-step facilitation. It's a manualized treatment protocol that is used by treatment centers, and the goal is to introduce patients in treatment to the language of the AA, the principles of AA, and then encourage them to continue involvement in AA after treatment. So those that were attending or had that type of experience in treatment, they said that we should basically inform them that there was no evidence that AA was very effective. And actually, there were folks that recommended or stated that recommending patients to go to AA was actually malpractice, because there was no evidence that it did any good. Of course, it didn't seem to do any harm either. But that was from 2006. Things have changed since, and we'll talk about that towards the end. The thing about every study, right, there are biases. If you look more closely at data, you can always find something that's either a little funky or has been maybe reported through a bias. And when you looked at the Cochrane article from 2006, a lot of it was based on this study by Diana Chapman Walsh, and they took people that were in an EAP program. They were considered alcohol abusers, which now is mild alcohol use disorder, and they randomized, quote unquote, these folks to go to a hospital inpatient treatment, go to AA meetings, or they gave the third group a choice of whether to go to AA or not. And what they found out is that, those that went to hospital inpatient had much greater percent abstinence at 2 years than those that just went to AA meetings or had a choice of going to AA or not. Now, if you look at this on the surface, it looks like, okay, well, clearly people that go to treatment do fairly well. And if you just go to AA meetings or even do nothing, although that's less, there isn't really any improvement from AA in itself. However, looking more granularly at the data, the problem is that those that went to hospital inpatient also went to AA during treatment. So, these folks were randomized, quote unquote, but, really what it's showing to me is those that go to an inpatient treatment and AA, do doubly better than those that don't go to treatment or have choice. And AA meetings, of course, that was randomized as well. But one of the problems with randomizing folks that have a mental health diagnosis or are attending a widely available program is it's very difficult to randomize them to do one thing or the other and not cross-contaminate into other groups. So as for instance, the cross-contamination here was that people that went to hospital inpatient also went to AA. So, that's part of the reason why I think the Cochrane review in 2006 came to that conclusion. Why is AA difficult to study? Well, it's anonymous. Some people give their names, some don't. It's steeped in tradition. It's been around since the 1930s. There's a singleness of purpose in AA that the primary existence and purpose for AA is to, focus on those that are still drinking and help those that are still drinking. And the only requirement for membership is a desire to stop drinking. But AA has had a long time belief that they don't have opinions on outside issues, on politics, religion, whatever it might be. That the singleness of purpose is recovery from alcoholism and helping others that suffer from the disorder or the disease. The other thing is there are people that have been doing it for decades and they say, I know it works, no studies are needed. It's also, as we see, difficult to randomize individual into one treatment versus the other. There's cross-contamination a lot of times. And then it can be hard to determine, what is it? What are the elements of AA that are critical and what aren't? I mean, just going to AA is not well defined. What does that mean? Just going to meetings, just going to a speaker meeting, going to a group meeting, going to a big book meeting, getting a sponsor, doing the steps, doing some type of volunteerism, et cetera, et cetera. It's hard to kind of parse that out in studies.
Mark,
Yeah.
Mark, the other question I think is like quantity, right? When it says attend AA, is that like once a month, once a week, 3 times a week? Was that controlled for in any way?
We're going to look at some studies down the road here that look at that
Right.
specifically, because that absolutely is part of it, Pam. I mean, you can say you've gone to AA or that you go to AA and last gone 6-12 months ago.
Yeah,
Sure, that's true, I guess, by definition, but not really active participation.
right.
Critics of 12-step research, they kind of say AA is a cult and it relies on God as a mechanism of action. Those that have studied AA or participate in it realize that that's not really true. It's more important to understand that those of us with the substance use disorders cannot just rely on ourselves to recover, that we need help. And for a lot of folks, GOD means good, orderly direction. So taking some direction from others rather than running their own lives. They claim that individuals self-select to AA. In other words, those that are healthier go to AA. So it makes it look like, that group does better. People that go to AA are more motivated. That leads to better outcomes. And that those that have, fewer co-occurring mental health disorders self-select to AA. I know from professional and personal experience that is not true. And then there are some, of course, that don't think that 12 steps have any role in treatment of substance use disorders, and that we need to focus more on medications as we do for other illnesses. So there are two types of research. I talked a little bit about this. One is it looks at AA as a mutual help organization, right? A group of folks that get together in meetings. If you have more than one alcoholic meeting in a room, so two or more, that could be considered a mutual help meeting. And AA, of course, is, not formalized in that the group has to pay dues to a larger organization and give out reports, etc. It's fairly relatively low bar, but we're talking about AA as meeting attendance, basically. AA philosophy as a treatment modality is 12-step facilitation therapy, and that's what was looked at more closely in Project Match, and we'll talk about that in a little bit. So TSF, there's the goals of acceptance and surrender to a different way of recovery. And it really looks at all behavioral, emotional, cognitive, spiritual, and social principles. Part of the problem too is that the design for recovery or design for life in 12 steps has a lot of elements of, like cognitive behavioral therapy in it. Motivational enhancement therapy is kind of inherent in that as well. So these aren't mutually or completely exclusive principles that one exists in AA or doesn't exist in AA but only exists outside. There's a crossover in Venn diagram kind of a look. So, right, we do this research on 12 steps or AA, and we say, okay, well, people that go to AA seem to do better, but then there's all these confounding factors, right? Like, do people self-select, or do they have fewer co-occurring mental health disorders? Are they more likely to be motivated to recover? So we can look at two groups, one that doesn't go to AA and one that does, and say those that go to AA do better. But that doesn't necessarily prove causation, right? We can't say just based on that it's because of AA, that's the intervention element that has allowed group B to do better. And it's almost impossible in studying something like AA to be able to do that because of cross contamination, and people kind of end up doing their own thing. So how do we prove that a person A has some intervention X and ends up being person B that is recovering or healthier than person A? How do we prove that X caused that? Well, in this case, I mean, in other studies on medications, we can do double-blinded, placebo-controlled trials and all that kind of stuff, and that's the standard of investigation. But you can't placebo control attendance at AA. Although I've been to some meetings that I couldn't really tell whether I was in an AA meeting or not. Maybe that's a placebo control. I'm not sure, but we have to look at different things. Is there a strength of association? Does it look like there's a dose response relationship? Are studies consistent? Are they temporally correct in that, it looks like that people are, A with the are in the illness at point A and then have an intervention X and at point B are doing better? Does it look like it moves in a logical temporal direction? Is there specificity that we can show that the intervention does seem to affect recovery or AA attendance, let's say, more specifically? And then is there coherence with existing knowledge? Does it make sense? From a common sense perspective, does what we're seeing kind of make sense inherently? This was put together by Leanne Cascudis, she's from California, part of the alcohol research group, and has done a bunch of research, epidemiologist, done a bunch of research on AA and looking at ways to improve AA attendance in folks that go to treatment. Big believer in the 12 steps that they work. So strength of association, we're going to go through this pretty quickly because I know we're I don't want to blab on for too long, and this is a higher overview, but I'll go through some studies here. Strength of association. So this was from Journal of Study of Alcoholism and Drugs, 1998. They looked at over 3,000 male veterans at one point, and then at 1 year follow-up, and found that those that had attended AA or NA from months 9 through 12 had more abstinence, more freedom from problems related to substance use, seemed to be doing better from a psychiatric perspective, and also had higher employment. And they showed that, that 12-step attendance was pretty strongly related to positive outcomes than as compared to just outpatient treatment attendance. But that patients who went to both outpatient treatment and 12 steps groups combined seemed to do the best at 1 year in both substance use related problems and psychosocial outcomes, including employment. And so that was looking at a year. This is also the same data, but looking at it from at 1 year and then a 3-year follow-up, and showed that those that went to formal treatment in AA did about twice as well as those that just went to formal treatment. And it persisted at 3 years. And it looked like, although both of the groups grew in abstinence, I'm not quite sure why, there was still about double the abstinence in those that had gone to formal treatment plus AA. We'll talk a little bit more about, what does that mean, going to AA or attending AA? Is there a frequency or intensity element involved? So that showed that there's a strength of association. Is there a dose response relationship like Pam's talking about? Now, bunch of different articles here. I obviously won't go into great detail. The earlier ones mostly done on males through the AA, but findings included that those that went to 3+ meetings per week while in treatment were more likely to attend AA and other 12-step fellowship programs after treatment. 3 seemed to be the magic number. And that after treatment, the more meetings a person went to, the more they were likely to remain abstinent or in recovery. And that weekly attendance predicted abstinence, not monthly. So if someone went never in the past 6 months, so said, oh, I attend AA, when's the last time you went? 6 months ago. 30% were abstinent at 2 years, less than weekly, 40%, and then weekly we're 75% abstinent. So at least weekly on those. Again, there's a dose response relationship there. More 12-step meetings, higher abstinence. And this was published in 2004. Now it was looking at the frequency of meetings, either none, 2 to 4, or 5+, and abstinence at year 1 and year 8. And again, on average, just a rough number, people that went to more meetings, at least 3, kind of being the magic number, had about double the rates of abstinence as those that did not go to AA. And a dose response relationship seems to exist. It goes up as number of meetings per week increase. How about duration of meetings? Did you go to 7 meetings a week for 2 weeks and then none for 3 more weeks and then repeat the same thing over and over? Or did you consistently go to AA during certain periods? And did that make a difference? So those that didn't go to AA, we can see, but those that went to AA for 33 or plus weeks in year 1, double the rates. Looking at years 2 through 8, those that went consistently for many months, just about double the rates. So dose response, not only in number of meetings attended, but also, how how consistent were they in AA attendance at those numbers over time. So again, if we look at, attendance in AA meetings during the first 3 years, there was better remission from alcohol problems, lower levels of depression, so improvement in psychosocial outcomes, and they had better quality relationships. And they actually concluded that AA probably helped more people in this sample than anything else. And actually, Moose and Moose, which is a husband-wife research team out of California, have posited that we should recommend 12-step recovery only. That people should just be advised to go to AA and not be advised to go to treatment. That would be controversial for sure, and probably is steeped in some of their own biases. But if we look at all that, the frequency of AA attendance above a certain threshold seems to be about 3 per week was positively related to better drinking outcomes. So we've talked about strength of association, dose response. Is there consistency in different studies? I think we've already seen that. But this is looking at a couple of different studies here, BA inpatients, problem drinkers, and looked at people going to outpatient treatment, AA only, or both. And it appears that, consistently we've shown that those that go to some type of treatment and AA, presumably both during treatment and afterwards, do much better long term. Perhaps there's not double the rates compared to, outpatient only versus AA, but probably double the rates between nothing and going to treatment and AA both. Does it seem temporally correct? And is it specific when we look at these studies? Project Match. So this was, I believe, from 1989? I have to look again. I always forget. Yeah, it was from 1989, way back when, I think the Gremlins movie was still around. They did this study, which is the largest kind of psychosocial study ever done in the United States. It cost $27 million. It went on for 8 years. There were multiple sites, and what they were basically looking at is they were trying to determine if you could match people with alcohol use disorders to different types of interventions and get better outcomes. And if there were better outcomes, what were those elements and specifics that were involved? So they tried both so they used 12-step facilitation. There was cognitive behavioral therapy group, and then a motivational enhancement therapy group, or motivational interviewing. 952 outpatients, 5 sites, a lot of patients, CBT, MET, and 12-step facilitation. I show this slide because the follow-up is quite incredible when you look at it. From at the randomization point at 0.0 up to 120 months, 10 years, there was about 85% follow-up, which is pretty incredible for any study. So anyway, I don't know how they did that, but they did. It showed that frequency of AA meetings attendance and overall involvement in AA in months 1 through 6 predicted positive outcomes and abstinence in the next 6 months. So there was a temporal relationship between the attendance and persistence or occurrence of abstinence later on. This is looking at comparing the different interventions now at 12-step facilitation, CBT, and MET, 1-year follow-up, 3-year follow-up, basically showed that there really wasn't a statistical difference between these 3 interventions. And so the outcome was that maybe we can match people a little bit based on, let's say, anger or some type of personality profile, but overall, any of these or either of these interventions is about equally successful. Now, Project Match, these data have been reanalyzed, turned upside down, put in a blender, retaped together multiple times. And this was a 2003 article that did some really fancy statistical analysis of this data. And I can't explain, that. But what they basically have done is try to determine whether a motivated person is more likely to attend AA, and if they are they more likely to do better because of it? And then a level of psychopathology, are they likely to self-select into AA, and if they are, do they do better long term? So what it's showing here is that those that were more motivated actually were less likely to go to AA and more likely to have alcohol problems 2 years later. I think part of that is that motivation can be translated into self-sufficiency, possibly, that doing it my way is the right way kind of thing. So not necessarily being desperate enough to follow or willing enough to follow somebody else's recommendations or advice. And those that had worse psychopathology, there was no difference in AA involvement and no difference in alcohol problems long term. So, but those that did go to AA had better alcohol problems overall. But, it didn't look like people were kind of self-selecting into AA, which resulted in positive outcomes, particularly when it came to motivation. Further granular assessment of these data showed that those that had a supportive social system, interestingly, using TSF to get them in AA, they did better than those that had MET or CBT interventions, which is interesting because earlier studies showed that those that had less supportive social systems tended to go to AA. Those that had anger issues seemed, yes.
Just want to clarify, that's people who had a social system that was more supportive of continued alcohol use, not just supportive social systems, right?
You're right. You're right. Sorry about that. You're right.
Yeah.
So this was not supportive of recovery, supportive of continued. Yes. So you're right. Thanks for clarifying that. So I guess there's some, alignment there as well. One thing they did show is those that had anger issues seemed to do better using motivational enhancement therapy, motivational interviewing. There are a lot of angry alcohol dependent clients, I find, and it can be difficult to use motivational enhancement therapy when somebody is in the throes of disease, just because their executive functioning, rational ability to rationally make decisions is not quite up to par. But anyway, these were, looking at these data from earlier on in the match study, and that those with a higher dependence on alcohol or worse alcohol use disorders seem to do better with TSF versus CBT. Again, the problem I have is that CBT and MET, maybe even some DBT elements, are kind of inherent in the 12-step philosophy. So I guess my ultimate kind of looking at Project Match and how much it costs and for how long it went on, I guess the ultimate result for me is that we don't know. How's that? $27 million. You're welcome. Last element for establishing causation, do things look coherent with existing knowledge? Does it seem to make sense from a common sense standpoint? Um, so there evidence that, self-efficacy or the confidence to reduce and stop drinking is helpful. Now, this isn't the same, I think, as motivation in that, being motivated to continue the same behavior to recover. This is confidence that, if that you can do it, by following someone else's direction, being self-efficacy versus, self-confidence, so to speak. Project match, a participation, as we talked about before, in 1 through 6 months, did predict attendance and abstinence months 7 through 12. And looking at that data in ACER from 2003 showed it was also present at 3 years. Increased social support. Does that make sense? If people have better social support, does that make sense that they'd be doing better in life when it comes to substance use disorders or any mental health disorder? Yes, and it was shown that in these data as well in other studies. A involvement in the type of support received from A members were contributors to abstinence 3 years following a treatment episode. So that type of support being found in a 12-step fellowship was helpful. Having improved coping skills, does that make sense why people would be doing better? Well, of course. Those that were better at handling their problems in life and their emotions, etc., tended to rely on other things besides drugs and alcohol to cope. And general outcome, when we look at it, attendance at 12-step meetings was not as likely to be as helpful as becoming actively involved. So even more than just, attending AA in consistency wise and or numbers, it looked like it was important to also be involved in AA. So Kaskutis looked across 16 studies and showed that those that did better seemed to have a sponsor and were more involved now than they were in the AA in the past if they'd been involved in 12-step recovery previously. Next was leading an AA meeting and doing 12-step work, and then weaker relationship for sponsoring others and working the last 7 steps. I don't know why that is. I think probably, the fact that people work through the first 5 steps, which are pretty time involved, is a good maybe explanation of why those folks are doing better as far as AA attendance and psychosocial outcomes longer term. I don't know. Interesting though. All right, this is the Cochrane review now from 2020, and this was looking now at a larger number of patients. The first Cochrane review, it was, a couple thousand patients maybe. This was about 10,000 patients. And there were 27 studies. And they showed overall that those that went to AA through 12-step facilitation did better. Now, it wasn't twice the rates of abstinence or recovery that maybe we see in other studies. But for, this was basically looking at it very hard line. What is the kind of minimum or maximum that you can say from these studies? And I think it was pretty telling that, despite all this very strict, both selection and interpretation of these studies, that it still showed that those that went to AA and were 12-step facilitated did better at both 24 and 36 months. Also, there was a significant decrease in healthcare costs in these individuals that, were able to get abstinence. So, AA was not only good for the individual, but from a public health perspective was really important, especially in this day and age when having access to healthcare is it's becoming more and more difficult for folks. So, conclusions, the 1 through 6 of proving, quote unquote, that not only a correlation, but that we can prove causation. There's a strength of association 2 times higher abstinence in those that go to AA. Dose response relationship, if you go to more AA, seem to be more likely to be abstinent. Multiple studies and different follow-ups have shown this, so it's consistent. Prior AA attendance predicts subsequent attendance and abstinence. We did get that out of Project Match, so I guess that was worth 27 million bucks. And although it's hard to prove specificity when they look at all these data through different methods that I don't quite understand, specificity does seem to be present, and it does make sense when we look at common sense of treatment of those with mental health diagnoses.
Hey, Mark, we
Yeah.
are running a bit over, just so you know.
Okay, that's good because we're basically done now.
Okay.
Yep, this is just looking at, this can be these different sites can be used as a good resource for folks if they want to look at that. The summary we already talked about, and that I wanted to just say that I think it's important to clarify for folks what the differences really in reality are between AA and what kind of the reality versus sort of what people's perception of it has been throughout the years. And that, when we do encourage folks to attend AA, they do a lot better. So anyway, sorry I went a little over.
Oh,
I
no,
like to hear myself talk. Just
well, I think we weren't as clear as we can be about when the start times are. So thanks, Mark. This is always a great review because there is a lot, as you said, of just discussion around AA. A lot of people have kind of been turned off by the concept of it, especially some of the younger generation, I think. Even residents and trainees have a kind of a dim view of it, I think. And it's nice to see that, that for some patients, it definitely seems to help. Quick thing that I wanted to ask about, if you have a thought on this, is, there's a lot of other methods out there, especially around alcohol. I'm not saying these are good methods, but a lot of encouragement around like gaining control of your drinking, whether it's the Sinclair method with naltrexone or just kind of California sober, replacing it with cannabis. Just this idea of regaining how you relate to the substance rather than abstinent only. How have you seen AA groups handle that? Because that is there's been a bit of a shift, right? That way, somewhat, in terms of just reducing harms and not focusing as much on abstinence.
Yeah, healthy AA groups tend to focus on, that or treat that kind of as an outside issue and not something that necessarily needs to be discussed amongst the group, but more one-to-one basis and maybe with a sponsor. The other thing is that I think some of these different methods, California sober, et cetera, can work for some folks that maybe haven't developed severe alcohol use disorders.
Agreed. Yeah, number one. Yeah.
Those that have developed moderate or severe alcohol use disorders, that tends to just be a horrible plan.
But in general, wouldn't you say, Mark, that AA in general, promotes abstinence?
Yes. Yeah. I mean,
Abstinence
that
as opposed to just, drinking controlled or, not drinking, but using other drugs instead or something like that.
correct. It is an abstinence-based program. But, one of the thoughts is that if you can stay sober in a different way, or if you think you can control your drinking, go for it.
Yeah.
But if you find that you can't, we're still here for you.
Yeah, and that more moderate severe group, absolutely. I 100% agree with you, Mark, on that. That those are the people who attempt doing the other methods and it does not go well. And we often have those conversations ahead of time and it doesn't go well.
Right.
So yeah, 100% with you.
And there's no real way to compare, like SMART recovery, for instance, the same frequency of meetings, other, peer support, recovery strategies directly with AA. it's a more self-select group that
And
resonate
that-
toward.
I-
And
is there
accessibility.
is there
Yeah.
data on that?
Yeah. Yeah, accessibility is a big problem for
Mm.
smart recovery, I find. I
Are
mean,
there any studies looking at efficacy of smart recovery or some of those other non-AA peer support programs? Do you know? Sheila or Mark?
I have not seen good studies on smart
Mhm.
recovery that have proven much, but
Yeah,
Well, maybe one of the people in the journal club will find something. We'll find out.
Yeah.
that'd be great. I'd love to hear
Yeah.
about it. Yeah.
All right.
So
Thank you so
cool.
much for doing this. And I will make sure that we get this to the new fellows. I think this is an important topic for them to see. So
yeah,
thank you for doing this, and I'll make sure they get to see it.
Thank you for having me.
yeah. I
All
really
right.
appreciate it, Mark.
Thank you, everybody.
Yeah.
Really good. It's a good talk and a good historical perspective about